Hello, today we'll be talking about arrhythmias in the acute care setting. My name is Dr. Dennis Kim. I am a trauma surgeon and intensivist, currently a second-year fellow at the UCSD Division of Trauma, Surgical Critical Care, and Burns. In terms of the overall objectives of today's discussion, we'll be discussing and reviewing some of the basic mechanisms of arrhythmias that are commonly encountered in the ICU. We'll develop an approach to the various tachyarrhythmias, and we'll also focus on atrial fibrillation, which is one of the more common tachyarrhythmias that we see in the ICU setting. This chart is a flow diagram which helps us to categorize and classify the various types of tachyarrhythmias that may be encountered. Tachycardia is usually defined as a heart rate greater than 100 beats per minute. Depending on the QRS complex, it may be either narrow or wide. This will help us in terms of deciding and approaching the various arrhythmias that we may encounter. For the specific purposes of this talk, we'll be focusing mainly on the narrow complex tachycardias. With regards to the narrow complex tachycardias, the next question to ask is the duration of the RR interval, and more specifically whether or not it is regular or irregular. In patients that have a regular RR interval with a narrow QRS complex, the differential diagnosis includes number 1, sinus tachycardia, number 2, atrial flutter or fibrillation with a fixed AV block, and number 3, the various types of AV nodal reentrant tachycardias. In patients with irregular RR intervals and a narrow QRS complex, the two types of tachycardias we'll be talking about today are number 1, multifocal tachycardia, and number 2, atrial fibrillation, as well as atrial flutter. In terms of the basic mechanisms of tachyarrhythmias, there are really three major types of mechanisms. The first two, increased automaticity and triggered activity, deal mainly with problems with impulse formation, whereas re-entry mechanisms usually deal with problems with impulse conduction. Increased automaticity may arise from myocytes which are not normally arrhythmogenic. Triggered activity usually occurs in the setting of depolarization during the repolarization of a previously formed impulse, which results in an arrhythmia, which may be sustained or non-sustained. Re-entry is the most common cause of tachyarrhythmias and is responsible for the more commonly seen tachycardias such as atrial fibrillation, atrial flutter, and others, including PSVT. With regards to sinus tachycardia, this is usually as a result of an increased automaticity in the pacemaker cells. Sinus tachycardia is usually characterized by a gradual onset, and the heart rate is usually between 100 to 140 beats per minute. Remember, the maximal heart rate is usually defined as 220 minus the patient's age. As you look at the rhythm strip in the screen, it demonstrates uniform P waves and a regular PR interval. In terms of the etiology of sinus tachycardia, there are several possible causes. Number 1, the systemic inflammatory response syndrome or sepsis, pain or anxiety. Fever is also a very common cause of sinus tachycardia. Hypovolemia, drugs, usually exogenously administered catecholamines or anticholinergics, as well as issues regarded to left ventricular or right ventricular dysfunction, including ischemic heart disease, as well as various types of cardiomyopathy. In terms of the management of sinus tachycardia, the primary goal is to identify and treat the associated underlying illness. Often sinus tachycardia is a response to systemic disease, and it is usually well tolerated and does not require any form of primary treatment. The one exception, however, would include patients that demonstrate clinical signs or evidence of myocardial infarction or ischemia. In these patients, immediate institution of appropriate beta blockade is probably warranted Again, attention must be paid to the patient's underlying coronary artery disease as well as left ventricular dysfunction, as beta blockers are known to have a significant chronotropic as well as inotropic depressive effect. Paroxysmal supraventricular tachycardia is one of the more commonly encountered arrhythmias in the general population. There are more than 5 types of PSVTs, and PSVTs usually affect patients without an underlying history of structural heart disease. These arrhythmias are due to an accessory pathway in the conduction system between the atria and ventricles and may be located within the actual conduction system or external to it. There are a number of different triggers that may result in PSVT, including atrial stretch, irritability, as well as inflammation. PSVTs are usually triggered by a premature atrial contraction, and unlike sinus tachycardia, are characterized by an abrupt onset as well as termination. The typical rate may be anywhere between 140 to 220 beats per minute, and the rhythm strip may actually not demonstrate any signs of atrial activity, as the P waves may be masked in the QRS complexes. As stated previously, there are 5 types of PSVTs, the most common of which is AV nodal reentrant tachycardia, which the remainder of the discussion will focus on. With regards to management of PSVT, there are a couple of options. Number 1, patients may be asked to perform maneuvers that will increase vagal tone. Likewise, physicians may apply carotid massage. However, these maneuvers tend to be temporary and non-sustained. They may be beneficial insofar as they may demonstrate the actual underlying rhythm. Definitive management usually involves the administration of medications, particularly those that block the AV node and the reentrant pathway located there. Commonly used medications include adenosine as well as calcium channel blockers. Multifocal atrial tachycardia is an irregular atrial tachycardia which tends to affect the elderly, and more than half of these multifocal atrial tachycardias tend to occur in patients with underlying chronic lung disease. MAT is characterized by the absence of a single dominant pacemaker. There is also a significant association with electrolyte abnormalities, more specifically hypomagnesemia as well as hypophosphatemia and underlying coronary artery disease as well. MAT is characterized by multiple P waves, usually at least 3 P wave morphologies, and a variable PR interval, as demonstrated in the rhythm strip below. In terms of the management, aggressively replacing electrolytes is tantamount to successful management of MAT. In terms of pharmacological management, institution of either calcium channel blockers or beta blockade are reasonable management alternatives. Atrial flutter is the result of a micro reentry circuit that usually rotates in a counterclockwise fashion around the right atrium. It is an inherently unstable arrhythmia and may either convert to a normal sinus rhythm or degenerate into atrial fibrillation. Below, we see a rhythm strip which demonstrates a sawtooth pattern consistent with atrial flutter. The etiology of atrial flutter is similar to atrial fibrillation and includes, but is not limited to, ischemic heart disease, cardiomyopathy, myopericarditis, hyperthyroidism, pulmonary embolism, and a number of other possible causes. The atrial rate in atrial flutter usually varies between 240 to 320, and the ventricular rate may vary anywhere between 75 to 150 or higher, depending on the rate of conduction. If the ventricular response is variable, then atrial flutter tends to demonstrate an irregular rate. In terms of the management of atrial flutter, The overall algorithm is very similar to atrial fibrillation. 3 key questions must be asked before instituting therapy, provided that the patient remains hemodynamically stable without signs of underlying heart failure or ongoing ischemia. These include, number 1, the timing and duration of atrial flutter, specifically less than or greater than 48 hours. Number 2, the underlying left ventricular systolic function. And number 3, ensuring that pre-excitation syndromes such as Wolff-Parkinson White have been excluded. For specific management therapies, we'll save these for our discussion on atrial fibrillation. Again, the management is very similar. We had mentioned Wolff-Parkinson White, and we'll just spend a little bit of time talking about this pre-excitation syndrome. This is a recurrent SVT that usually originates from an accessory reentrant pathway, also known as the bundle of Kent, usually along the AV conduction system. Wolff-Parkinson White is characterized by a few things on the EKG. Number 1, there is usually a short PR interval. Number 2, the presence of a delta wave. And number 3, a wide QRS complex. These findings are usually the result of a prolongation of AV conduction as well as simultaneous stimulation of the ventricles through the normal conduction pathway as well as the accessory pathway. Agents that prolong AV conduction, including calcium channel blockers, may paradoxically accelerate the ventricular rate. Similarly, digoxin, which has more of a vagal effect, may also lead to a worsening tachycardia as well as degeneration into ventricular fibrillation if utilized in the setting of atrial fibrillation in someone with Wolff-Parkinson White syndrome. Atrial fibrillation. AFib is the most common cardiac arrhythmia in clinical practice. The prevalence of atrial fibrillation increases with age and overall tends to be about 1% in the general population. The prevalence of AFib tends to rise greatly with age, and more than 5% of patients over the age of 65 are affected with this disease. The incidence of AFib doubles with each decade of life. Atrial fibrillation is associated with an increased long-term risk of stroke, heart failure, as well as all-cause mortality. The rate of ischemic stroke in patients with non-valvular atrial fibrillation varies between 3 to 8% and on average is about 5% per annum. Rheumatic heart disease in the setting of or the cause of atrial fibrillation increases the stroke risk by 17-fold versus age-matched controls. In terms of the classification of atrial fibrillation, there are a number of ways of classifying it. One can think about it as acute or chronic. Acute usually occurring within 48 hours of onset, and chronic usually implying continuing AFib. Again, the problem with using this specific classification system is that the term chronic really does not address the clinical distinction between persistent and permanent atrial fibrillation. Paroxysmal, persistent, and permanent are more common ways of classifying atrial fibrillation. Paroxysmal AFib usually refers to intermittent, recurrent, and self-terminating atrial fibrillation, whereas persistent atrial fibrillation will not self-terminate but can be effectively cardioverted to sinus rhythm. Permanent AFib is defined by atrial fibrillation that cannot be terminated by cardioversion or can be terminated only for brief intervals or last longer than 1 year without cardioversion attempts having been tried. Atrial fib can also be classified as primary or secondary. Secondary causes of atrial fibrillation include in the setting of an acute myocardial infarction, postoperative from cardiac surgery, as a result of hyperthyroidism or thyrotoxicosis, myopericarditis, as well as acute pulmonary disease. The key between primary atrial fibrillation and secondary atrial fibrillation is that if AFib is due to a secondary cause, the secondary cause should be addressed primarily, while other measures are being instituted to control AFib. The primary importance of this classification is that for secondary causes, therapy should be directed primarily to the underlying cause of the atrial fibrillation. Again, one of the other important distinctions is distinguishing between non-valvular and valvular atrial fibrillation. And the primary importance of this is that non-valvular atrial fibrillation, particularly in the setting of patients who are already anticoagulated, poses a lesser risk of stroke in the setting of withholding anticoagulation. As previously mentioned, the risk of stroke in the setting of valvular atrial fibrillation is quite high. Finally, lone atrial fibrillation is another form of AFib, which is usually characterized by the absence of underlying cardiac disease or a history of hypertension in patients less than age 65. Atrial fibrillation is usually precipitated by an underlying cardiac or non-cardiac disease, and the resultant atrial abnormality acts as a substrate for the development of the arrhythmia. The onset of atrial fibrillation usually requires a trigger, and these were previously discussed. Results from the Framingham study demonstrate a number of independent risk factors for atrial fibrillation, and these include male sex, the presence of hypertension, diabetes, heart failure, as well as valvular heart disease. Hypertension is by far the most common underlying risk factor for atrial fibrillation, and this is secondary to the significant prevalence of hypertension in the U.S. population. Other risk factors for atrial fibrillation may be established via echocardiography, either transthoracic or transesophageal, which tends to be much more sensitive and specific. These findings include evidence of left atrial dilatation, left ventricular hypertrophy, as well as impaired systolic function, particularly in patients with an ejection fraction less than 35%. Of course, one of the significant consequences of atrial fibrillation are its impact on overall cardiovascular hemodynamics. It's important to bear in mind the determinants of cardiac output. These include, number 1, preload, number 2, contractility, number 3, afterload, and number 4, heart rate. The associated loss of the atrial contribution to stroke volume and ventricular filling may result in the loss of approximately 20 to 30% of the overall stroke volume. Likewise, the irregularity of the ventricular response may also have an important role, as uncontrolled atrial fibrillation may result in increased mitral regurgitation, tachycardia, and the so-called tachycardia-induced cardiomyopathy. Poorly controlled ventricular rate with a mean greater than 100 beats per minute may result in these ultrastructural changes that causes the underlying ventricular dysfunction. In terms of the other causes of atrial fibrillation, one can think about it in terms of reversible causes, with or without associated conditions, and there are also familial causes of atrial fibrillation. Of course, thromboembolism is one of the most feared complications of atrial fibrillation, and this is usually as a result of stasis, and this is most marked in the left atrial appendage, which is the most common site for thrombus formation in patients with atrial fibrillation. As stated previously, the annual stroke risk is approximately 3 to 8%. It is important to bear in mind that approximately 1/4 of patients with atrial fibrillation may have an ischemic stroke that is not secondary to the atrial fibrillation itself. This may be due to primary cerebrovascular progression of disease, secondary to proximal erythematous disease of the aorta, or other cardiac foci, not secondary to thrombus formation in the left atria or atrial appendage. The key underlying reasons for thromboembolism in atrial fibrillation are similar to those in venous thromboembolic disease, and these include stasis, hypercoagulability, as well as endothelial dysfunction. The importance of atrial fibrillation on quality of life has been studied in a number of different investigations, and thus far the available data suggests that quality of life is markedly impaired. Studies have shown that sustained sinus rhythm has been associated with improved quality of life as well as exercise performance. In terms of the approach and diagnosis, it's important to determine the clinical significance of atrial fibrillation and to identify any associated conditions that may also require treatment. In terms of deciding upon medical therapy for atrial fibrillation, we must pay attention and be aware of the potentially negative impact that certain types of drugs may have on underlying cardiac function, particularly those that may impair left ventricular systolic function. A careful history and physical, of course, are mandatory, and one should obviously seek signs for evidence of a new onset or exacerbation of angina or CHF, as these patients may benefit from immediate cardioversion. Echocardiography may be an indispensable tool in terms of evaluating cardiac abnormalities. 3 key principles must be adhered to in the management of atrial fibrillation. Number 1, rate control. Number 2, the prevention of thromboembolism. And number 3, correction of rhythm disturbance. For the remainder of the talk, we'll be focusing mainly on rate control as well as the prevention of thromboembolism. In the early 2000s, there were approximately 5 randomized trials comparing rate control with rhythm control in patients with atrial fibrillation. The AFFIRM trial was by far the largest of these trials, including more than 4,000 patients over the age of 65. In this study, there was no difference in terms of all-cause mortality, and in terms of complications, there was likewise no statistically significant difference. This Kaplan-Meier survival score demonstrates that in fact there appeared to be a trend towards improved survival in patients undergoing rate versus rhythm control. However, again, this did not reach statistical significance. Unadjusted subgroup analysis, 2 groups demonstrated improvements with rate control: patients with underlying coronary artery disease, as well as patients with no history of congestive heart failure. With regards to rate control, it is important to ensure appropriate control of the ventricular rate while the patient is in atrial fibrillation. An important concept to bear in mind is that the functional refractory period of the AV node is inversely related to the ventricular rate during AF. This table demonstrates the various pharmacologic interventions and drugs that may be used both in the acute care setting in patients with and without accessory pathways. In general, beta blockers and calcium channel blockers are recommended as first-line therapy for patients with atrial fibrillation without a documented accessory pathway. Amiodarone is another drug which is frequently used in the ICU and may be used in patients with accessory pathways as well. Regarding prevention of thromboembolism, there are several risk factors that may predispose patients to an increased risk for ischemic stroke and systemic embolism. These include previous stroke or TIA, or transient ischemic attack, diabetes, a history of hypertension, heart failure, as well as advanced age, specifically defined as age greater than or equal to 75. On a multivariate analysis in patients not taking aspirin, as you can see, patients with a CHADS-2 score of 6 have an overall adjusted stroke rate of 18.2% per year. It is very uncommon to have patients with a CHADS-2 score of 0 or 1. In terms of overall therapy for the prevention of thromboembolism, there are significant number of randomized trials that have been published since 1990 in patients with non-valvular AFib, totaling more than 20,000 patients. Overall, the consensus appears to be that adjusted dose oral anticoagulation leads to a risk reduction of stroke of 61% compared to placebo. Again, many of these trials are limited by duration of follow-up, which on average is anywhere from 1 to 2 years with a maximum of 2.2 years. And again, most of these studies excluded patients that were at a high risk for bleeding. With the introduction of newer direct thrombin inhibitors, the ability to manage these patients may be significantly improved. However, the increased risk for bleeding and inability to administer an antidote in the setting of bleeding is obviously of major concern. In terms of the target intensity, again, this is a fine balance between prevention of ischemic stroke and hemorrhagic complications, which may occur on the order of 0.1 to 0.6%. But in general, the target INR for patients who are placed on vitamin K antagonists such as warfarin is between 2 to 3. As you can see from this chart, the risk for intracranial bleeding starts to increase significantly in patients with an INR greater than 4. Likewise, the occurrence of stroke in patients who are on anticoagulation usually occurs in the setting of inadequate anticoagulation with INRs less than 2.0. Regarding antiplatelet medications for the prevention of thromboembolism, ASA does offer modest protection. It offers nowhere near the risk reduction that would be achieved with vitamin K antagonists. Again, the stroke risk reduction is approximately about 20% in patients on aspirin. It should be emphasized that thus far, data does not support the use of combination oral anticoagulation and antiplatelets, as this has not been shown to reduce either the risks of hemorrhage or augment the efficacy of oral anticoagulation alone. In general, it is recommended that in patients who do not have stents and require antiplatelet agents, remain on oral anticoagulation alone, as this should provide sufficient cardiac as well as cerebrovascular protection. The story, of course, is different for patients who have undergone PCI with stent placement, as these patients will oftentimes require, at minimum, the administration of an antiplatelet agent, i.e. clopidogrel, for a minimum of 12 months concurrent and along with their oral anticoagulation in the form of warfarin or one of the newer direct thrombin inhibitors. Outside of rate control, and especially in patients who document evidence of ischemic heart disease, angina, or heart failure, cardioversion is another therapeutic modality which may be employed. This may be performed either pharmacologically or electrically. Cardioversion, whether pharmacologically or electrically, does carry a small but significant risk of thromboembolism. The data behind this is sparse, but approximately 1 to 7% of patients not given prophylactic anticoagulation may develop a stroke once cardioverted. Transesophageal echocardiography has been advocated as a means of determining which patients may require anticoagulation prior to cardioversion. The key with regards to anticoagulation for cardioversion is that any patient that has had documented atrial fibrillation or flutter for greater than 48 hours should be placed on anticoagulation for a minimum of 3 weeks prior to attempted cardioversion, and of course, provided that their physiology allows this, this should be followed by a further 4 weeks of anticoagulation. For patients who are demonstrating signs of angina or heart failure, immediate cardioversion is warranted. If possible, these patients should be administered pre-cardioversion anticoagulation with systemic unfractionated heparin, or administered this therapy concurrent to cardioversion. Regarding direct current cardioversion, success depends both on the underlying heart disease as well as the current density employed. Studies have demonstrated that a high initial energy, specifically greater than 200 joules, is associated with statistically significant more successful rates of cardioversion than lower energies. Key caveats to bear in mind when performing direct current cardioversion is that patients must be given conscious sedation. In patients with pacemakers and defibrillators, it is important to bear in mind that direct current cardioversion is not contraindicated. In fact, most of these devices have been implanted with circuits that will protect against external surges. However, data may be lost, and as such it is important, if time allows, to get in touch with their AP colleagues to either turn off these devices or to ensure that they follow up with them following electrical cardioversion. The maintenance of sinus rhythm, again, is something that we don't usually deal with in the acute care setting, but the point here is that this can be done either pharmacologically with either class 1, 2, 3, or 4 agents. Again, the specific regimen, dosing, and duration is dependent on a number of underlying host as well as structural factors. Non-pharmacologic means of intervention are usually employed in patients who have failed multiple trials of medical therapy. Non-pharmacologic therapies include surgical ablation, more specifically the Mays procedure, which has undergone more than 3 iterations since being introduced in the 1980s. Other options also include catheter ablation of the macro pathways responsible for atrial fibrillation. This may or may not include also AV nodal ablation with pacemaker insertion, and newer modalities on the horizon include internal atrial defibrillators. In terms of the take-home points, tachyarrhythmias are very common in the acute care setting. One of the most commonly encountered tachycardias or tachyarrhythmias is atrial fibrillation, and the key goals of management with atrial fibrillation, once again, include rate control, prevention of thromboembolism, and maintenance of sinus rhythm if this has been restored. Thank you.